Good evening, all. We'll talk about the management of nausea, vomiting in pregnancy, and hyperemesis gravidarum. This is the recent RCG Green Top Guideline number 69, released on 4th February 2024. The key recommendations and objectives and validated index of nausea, vomiting in pregnancy. That is the PUQE, that is pregnancy unique quantification of emesis and hyperemesis level predictions. That is helps tool can be used to classify the severity of the nausea vomiting in pregnancy and hyperemesis gravidarum. Ketonuria, basically remember ketonuria is not an indicator of dehydrations, should not be used to assess the severity. So ketonuria should not be used to assess the severity. There are safety efficacy data for the first line antiemetics such as antihistaminic, that is phenothiazines, doxylamines, and pyridoxines. They should be prescribed initially when required for nausea vomiting pregnancy. There is evidence that ondansetron is safe and effective. It uses second line antibiotics, should not be discouraged. If first line antibiotic ineffective, you can use ondansetron, but there is can be reassured regarding the very small increase in the absolute risk of orofacial clefting with ondansetron used in the first time. So it should be balanced with the risk of poorly managed. If it is very ineffective, then you can start ondansetron based on the material conditions. Metoclopramide is safe, effective, can be used in combination with other antiemetic. Because of the risk of extrapyramidal effect, metoclopramide should be used as second line therapy. IV dose should be administered slow bolus injections over last at least 3 minutes to help minimize this. You can give IV bolus over 3 minutes. Women should ask to previous adverse reaction to antiemetic therapy. If adverse reaction can occur, there should be prompt cessation of the medications. Normal saline 0.9% NSL with additional potassium chloride in each bag with administration of guided by daily monitoring of electrolyte is the most appropriate in IV administrations. Combination of different drugs should be used in women who don't responding to the single agent. Uh, Thiamine supplementation, like either you can give oral tablets 100 mg 3 times daily or intravenous as a part of vitamin B complex. Fabrinex should be given to all women who are admitted with vomitings or severely reduced dietary intake, especially before administrations of dextrose or parental nutrition. All therapeutic measures should be tried before considering termination of pregnancy. The nausea vomiting of pregnancy. How are nausea vomiting pregnancy and define and diagnose? The diagnosed when onset is prior to 16 weeks of gestation, and other causes of nausea vomiting has to be excluded. Okay. Then can be diagnosed when symptoms start in early pregnancy. Nausea and or vomitings are severe enough to cause inability to eat, to drinks normally, and strongly limits the daily activities of living. Signs of dehydration are contributed to the diagnosis. An objective and validated index of nausea vomiting such as the pregnancy unique quantification of emesis and hyperemesis level predictions tool can be used to classify the if you classify the severity, then you need the PUQE, pregnancy unique quantifications, emesis and hyperemesis level predictions tools. Clinicians should be aware of this feature in history examinations investigations that allow nausea vomiting and hyper to assess their severity to be monitored. Ketonuria itself is not an indicator of dehydration. Very important statement they have told. So it should not be used as to assess the severity based on the ketonuria. Then the features in the history examination investigation that will add to the diagnosis and that can exclude other causes of severe nausea vomiting in pregnancy. First, in history, you should ask: is there any history of previous history of nausea, vomiting in pregnancy, or hyperemesis gravidarum? You can quantify the severity using the pregnancy unique quantification of MSS or help tools score, that is nausea, vomiting, hypersalivation, splitting, weight loss, inability to tolerate food, fluids, effect of quality of life, ability to perform daily activities. Ask about self-reported nutritional status or any rapid weight loss. Ask about comorbidity, which may complicate this by lack of oral intakes of essential medications such as epilepsy can be aggravated, complicated diabetes, HIV, psychiatric conditions, hypoadrenalism. So relevant surgical history such as gastric bypass surgery or bands, ligation, sleeve surgery. So in history to exclude other causes, you also should ask whether there is abdominal pain, any urinary symptoms, you have to rule out UTI, infections, any drug history, prescriptions and recreational, chronic H. pylori infection have to be ruled out. In examination, you should look for the temperatures and the heart rate. Here there is tachycardia and dehydration because of there. Blood pressure, hypertension is there or not. Oxygen saturations, respiratory rate, tachypnea occur in dehydration. Abdominal examination has to be done. Weight reductions is there or not. Signs of dehydration such as shrunken eye, dry lips, mouth, oliguria, anuria, tachycardia, and hypertension. The signs of dehydration you have to remember: shrunken eye, dry lips, oliguria, anuria, tachycardia, hypertension. Sign of malnutrition or rapid weight loss more than 5%, more than equal to 5% pregnancy weight, and muscle wasting measurement by mid-arm circumference. Neurological signs like confusion, nystagmus, ataxia, which could indicate Wernicke's encephalopathy. The investigation, urine analysis, you can go for a urine analysis to rule out UTI. Nitrate may indicate infections. The presence or absence of ketonuria in pregnancy. Whatever ketonuria is not an indication, not an indicator of dehydration. Assessing the urine ketone does not have a use in the management of nausea, vomiting, or hyperemesis gravidarum may be misleading. Midstream urine, if dipstick, is indicate signs of UTI. Urea and electrolyte to guide in IV fluid and electrolyte replacement. You have to monitor the urea and electrolyte. Hypokalemia or hyperkalemia, hyponatremia, chronic kidney disease has to be do to rule out. You have to do all this. High creatinine urea, acute kidney injury due to dehydrations, full blood count to rule out infections, anemia, raise hemoglobin, hematocrit, blood glucose level to diagnose diabetes, exclude diabetic ketoacidosis, special diabetes, ultrasound to assess the fetal viability, to locate the intrauterine pregnancy, whether it is multiple pregnancy, whether it is a gestational trophoblastic disease, or in refractory cases or history previous admissions. Check whether there is TFT has been done or not, hypothyroid or hypo or hyperthyroid LFT to exclude liver disease such as hepatitis, gallstone disease, monitor for malnutrition, calcium phosphate level has to be checked, amylase to rule out exclude pancreatitis, BBG has to be done to rule out metabolic disturbance and monitor the severity. So, what are the initial clinical assessment? Baseline investigation should be performed. Women with mild nausea, vomiting should care for the community with this antimalarial. Ambulatory daycare should be used when community measures have failed. Inpatients should be considered when you admit the patients if there is at least one of the following. Is what are the one of the following? Continued nausea and vomiting, inability to keep oral antiemetic, continued nausea, vomiting associated with clinical signs of dehydration, clinical signs of weight loss greater than 5% body weight despite oral antiemetic, confirmed or suspected comorbidity such as UTI, inability to tolerate oral antibiotics, comorbidities such as epilepsy, diabetes, HIV, hypoadrenalism, psychiatric disease, where symptoms and inability to tolerate oral intakes that could medication could present further complications. When patient's care is required, an ultrasound scan should be scheduled to confirm the viability and the correctal gestational age to assess the multiple pregnancy or singleton gestation or aplastic disease. Unless there are other medical reasons for an urgent scan, this can be scheduled for the next available appointment. What the pharmacological therapeutic options available? What are the effective for women with nauseative vomiting pregnancy and hyperemesis gravidarum? The combinations of different drugs should be used in women who don't respond to the single antiemetic suggested. Mm, a delayed release combinations of doxylamine pyridoxines is the only licensed treatment of nausea vomiting in the UK, so can be used first line for mild to moderate nausea vomiting. For women with persistent or severe hyperemesis gravidarum, the parenteral, transdermal or rectal route may be necessary and more effective than an oral regimens. Corticosteroids should be reserved for cases where standard therapies have been ineffective and used in combination with antiemetics. So basically, I have a initially you can start a single agent. If it is not effective, you can go over a combination agent. If orally not tolerated, you can go for a IV or parenteral route or transdermal rectal route. If corticosteroid is the last resort, if anything is not effective, the combination therapy also. So then you can go to corticosteroid. The additional second line drugs you can use. Second line drugs, you have a metoclopramide, that is a safe, can be used alone or it can be used in combination with other antiemetic drugs. Because the risk of extrapyramidal side effect, the metoclopramide should be used as a second line therapy. IV dose, so because of this, so IV dose should be administered very slowly, bolus injections over at least 3 minutes to help minimize this. Okay, so very slowly you have to go over 3 minutes to have to complete the dose, so that it will decrease the extrapyramidal side effect. Women should ask about previous adverse reaction to, if they have a previous adverse reaction to any antiemetic therapies, so should not give that same drugs. If adverse reaction occur, there should be prompt cessation of these medications. What is the safety of the pharmacological agent to treat nausea, vomiting, and hyperemesis? The first line therapy, there is a safety antiemetics such as antihistaminic, phenothiazine, pyridoxine, doxylamine. This should be prescribed initially. Second line, there are evidence that ondansetron is safe, but should not be used, should not be discouraged to use. Discouraged if first line antiemetic is ineffective. If it is ineffective, then you can use, but there is should reassure regarding very small increase in the absolute risk of orofacial cleft lip undernecessary use in the first trimester, which should be balanced with risk of polymanous hypergamic hyperthermia. What are the adverse effects occur? How can they prevent it? Mainly the electrolyte imbalance is happening in the nausea, vomiting, and pregnancy. The urea and serum electrolyte should be checked daily basis in women requiring IV fluid. If they are requiring IV fluid, you should go for a daily checking of the urea electrolytes level. Serum electrolyte. Histamine, a type 2 receptor blocker, proton pump inhibitor. If this may be used for those, if you suspect there is a gastroesophageal reflux disease or esophagitis or gastritis, so you can go for H2 blocker like proton pump inhibitors. Thiamine supplementation, that I can give oral 100 mg TDS or IV as a part of vitamin B complex, should be given to all women. Admit those patients with admitted the vomiting or severely there have a reduced dietary intake, especially before you go for a parenteral or dextrose solutions infusions. Women admitted with hyperemesis should be offered thromboprophylaxis with low molecular heparin, and those being managed in community basis should be assessed for venous thromboembolism. The graduated compression stocking should be used when low molecular weight is contraindicated. Thromboprophylaxis can be discontinued upon discharge providing no other indications exist for continuation of prophylaxis. Okay, so thromboprophylaxis basically you should go if it is severe hyperemesis gravidarum. Women with previous history of previous or current nausea pregnancy should consider avoid iron containing preparations. Very important, you should avoid iron containing preparation if this exacerbate the symptoms, or you can consider alternate route of administration of iron, like you can give IV injections, infusions, FCM or carbapenems. Okay, women should questions about their bowel habits and offer laxative if constipated, particularly if they're undecided cause constipations. Women should offer treatment with proton pump inhibitors for gastroesophageal reflux disease. The treatment of GSD with antiemetic therapy has been associated with reduced PUK scores. How should women with nausea should be offered ongoing antenatal care? Should only be discussed once the appropriate antibiotic therapy has been tolerated, adequate oral nutrition and hydration has been tolerated, manage concurrent conditions. After at the time of discharge, it is essential that women are best to continue their antiemetic and appropriate. They know how to access further care. Women with severe and nausea-vomiting pregnancies, continuous symptoms, late second trimester should be offered serial scan to monitor fetal growth. Low pregnancy weight gain and increased preterm birth, low birth weight. Then what are the optimal rehydration regimen? Normal saline is 0.9% NaCl with additional potassium chloride in each bag with administration guided by daily monitoring of the electrolyte is the most appropriate IV additions. There is no evidence to know which fluid regimen most appropriate, but given the most women admitted to the hospital with hyponatremic, because they are hyponatremic, hypochloremic, hypokalemic, it seems to better to use the NaCl with potassium chloride. The dextrose infusions or fluid replacement is not recommended. In IV fluid electrolyte replacement is likely the most important intervention treatment of those requiring ambulatory inpatient care. General guidance on fluid management adult can be nice. Initial dextrose containing solution may precipitate warnix encephalopathy in thiamine deficient patients. What are the effect on the quality of the life and the family? Women quality of life can be adversely affected in nausea and pregnancy. The patient should be access the severity of the woman's symptoms, relation to her quality of life, social situations. day-to-day negative effect in the relationship with partners and family. Should carry out full assessment of the both physical and mental health status during the pregnancy. Refer to a psychological support if necessary. Depressive symptoms, poor mental health are associated with Nausea acknowledged by healthcare professionals. Physical symptom pre-existing mental health conditions may be exacerbated by hyperemesis, particularly where prescribed oral. If you are not taking, unable to take the oral medications, being taken, skipped down because of vomitings, that were considered alternate route of administration. Proactive use of antiemetic appropriate referral should be considered. Information about patient support groups should be provided all women and nausea pregnancy. Okay. Then how should what are the role of multidisciplinary in severe nausea vomiting? Input should be sought for other professionals. When should enteral parental nutrition should be indicated? When all other medical therapy have failed sufficient to manage symptoms, enteral tube feeding parental treatment should be considered with referral gastroenterology and multidisciplinary approach in parallel ongoing medical therapies. Total parental is a high risk intervention, however, it is may be useful in refractory cases to ensure sufficient nutritional intake. When should termination of pregnancy should be discussed? All therapeutic measures should have been offered before considering the terminations. Hyperemesis is associated with higher risk of terminations of the pregnancy. As many as 10% women undergo termination pregnancy due to severe symptoms who would not otherwise choose to. What are the long-term effects of nausea, vomiting in pregnancy? There is no evidence of a significant impact on long-term all cause of mortality. Women who experience hyperemesis in at increased risk of paroxysmal nocturnal dyspnea, anxiety, postpartum stress disorder. Women with previous advice that there is a risk of recurrence in future pregnancy. The reported is recurrence is 15 to 81%. What are the advice should be given about future pregnancy? Early use of lifestyle, dietary modification, antiemetic that you are useful in the index pregnancy as advised to the risk of nausea pregnancy and hypertonic current pregnancy. There is a lower recurrence risk with preemptive antiemetic before symptom begins. Okay, these are the recommendations added to topics. Um, Thank you.